Dynamed.com, a leading authority in patient education, presents this video to help patients and their families better understand their medical condition and its management.
About a year ago, I was playing a pickup football game with a bunch of friends, and I was wearing cleats for better traction, but when I cut one way, my cleats didn't give, and it just felt like the bones separated. I went straight to the ground, a lot of pain. I wasn't able to get up. I looked down, my knee was about the size of a grapefruit, and I knew I had done something wrong.
The ACL, or anterior cruciate ligament, is a ligament in the center of the knee that becomes damaged when twisted too far. The anterior cruciate ligament is most commonly injured during sporting activities when an athlete suddenly pivots, placing excessive rotational force on the ligament. The ACL can also be torn during severe trauma, such as in a car accident or as the result of a work injury. In considering a tear to the anterior cruciate ligament, it's helpful to take a look at the anatomy of the knee. The bones of the knee, the femur or thigh bone, and the fibula and tibia bones of the lower leg meet. The front of this joint is protected by the patella or kneecap. Like all joints, it is cushioned by articular cartilage, a kind of protective padding that covers the ends of the tibia and femur as well as the underside of the patella. Pads of cartilage, known as the lateral meniscus and medial meniscus, further cushion the joint, acting as shock absorbers between the bones. A ligament is made of tough fibrous material and functions to control excessive motion by limiting joint mobility. There are 4 ligaments that are critical to the stability of the knee joint. The anterior cruciate ligament begins at the back of the femur and inserts on the top of the tibia. Its function is to limit the forward motion of the tibia on the femur. Without ligaments to stabilize and restrain the knee, the joint would be prone to dislocation. The ACL also helps maintain stability each time one straightens or rotates the knee. In addition to the ACL, the collateral ligaments, the medial collateral ligament or MCL, and the lateral collateral ligament, LCL, run along the sides of the knee, limiting sideways motion. The posterior cruciate ligament, PCL, limits backwards motion of the tibia. These components of the knee, along with the muscles of the leg, work together to coordinate the motion of the legs as you walk, jump, run, lift, and climb. Injuries to the knee can dramatically limit the ability to move. There are several types of knee injuries depending upon which component has been damaged. Cartilage or meniscus injuries involve tears or deterioration of the cartilage, while tendon injuries result when the tendon or structures attaching the muscles to bone become ruptured, torn, or inflamed. Ruptures of the anterior cruciate ligament happen when the tibia moves too far forward or when the knee is hyperextended. If the knee is twisted violently, the ACL may not be the only ligament torn. Doctors often see simultaneous injury in both the medial collateral ligament and the ACL. Complete and incomplete ruptures of the ligament produce bleeding into the knee that cause the knee to swell and cause pain. The immediate application of ice to the injury can help limit this rush of blood into the joint. Once torn, the knee usually becomes noticeably unstable, and the ACL has a relatively poor vascular supply and therefore will not heal without medical intervention.
So then I went to the orthopedic surgeon the next day, and he stuck a needle in my knee to suck out a lot of the blood that was in it, and it made it actually feel a whole lot better. And he was pretty sure at that time that I had torn an anterior cruciate ligament. And then he got an MRI the next week to confirm it, and sure enough it was.
The physician may aspirate the joint using a syringe to drain the swollen region of fluid. If blood is discovered while draining the knee, it's likely to be the result of a torn ACL. A magnetic resonance imaging machine, or MRI, may also be used to evaluate injuries to the joint. The MRI uses magnetic waves rather than X-rays to examine the soft tissues of the body. Injuries are very clearly visible with this painless test. At times, bone scans or CAT scans are also used. Occasionally, arthroscopy is used to make a definitive diagnosis. Non-surgical treatment is usually recommended for patients who do not regularly participate in high-demand sports involving cutting or pivoting. The three components of non-surgical treatment are physical therapy, activity modification, and the use of a brace. A special brace fitted by a physician or physical therapist can help prevent the knee from giving way during strenuous activity. Since most orthopedic surgeons recommend wearing a brace for at least 1 year after surgical reconstruction, the brace is a good investment even if the patient should decide to have surgery. There are a number of surgical methods for reconstructing the torn ACL, and the type of procedure chosen depends on the judgment of the surgeon, who considers factors unique to each individual patient. In most cases, the ACL is reconstructed using another tendon from around the knee. The material used to reconstruct the ligament is called a graft. This is often an autograft from one's own body. The most commonly used form of ACL reconstruction today uses a patellar tendon autograft. This graft makes use of the central or middle third of the patellar tendon and its attached piece of bone from both the kneecap or patella and the tibia. Because of the structures involved, this is known as a bone-tendon-bone graft. Another very common graft involves combining two of the hamstring muscles tendons attaching to the tibia just below the knee joint, the gracilis tendon and the semitendinosus tendon. These two tendons can be removed without really affecting the strength of the leg, as there are other larger and stronger hamstring muscles that can take over the function of the two tendons that are removed. Arthroscopy is usually used for the surgical procedure. Arthroscopy enables a doctor to see into the joint and make repairs through a very small incision, rather than the large incision needed for open surgery. Pencil-sized instruments, along with a small lens and lighting system, magnify and illuminate the structures inside the joint. This technology makes possible much more precise treatment of specific parts of an injury. In typical reconstructive surgery, the torn ends of the ACL are first removed. In most cases, the graft is taken from the patellar tendon, and a tunnel is drilled into both the tibia and femur. The graft is threaded across the knee. The patellar tendon is secured in the position of the original ACL by wedging a screw between the side of the bone and the tunnel. Other securing techniques may involve using staples, sutures, or small anchoring devices to be permanently left in place.
After the surgery, I wasn't able to do a whole lot. They just had me doing leg lifts and things like that. It was still pretty sore. But after that, they really wanted me to get my range of motion back, and that was the most important part of it.
Following ACL reconstruction, rehabilitation includes controlling the pain and swelling, regaining knee motion, and regaining muscle strength. The leg is placed in a brace after surgery, and a continuous passive motion machine may be part of the initial rehabilitation protocol. Crutches are required for 2 to 3 weeks. Although as swelling decreases and muscle strength improves, the patient progresses to putting full weight on the leg, independent of crutches. This phase of treatment typically takes 6 to 12 weeks. From 3 to 6 months after surgery, the patient is encouraged to begin activities such as cycling, treadmill running, and light jogging. Swimming is also an excellent method of strengthening the muscles around the knee. Graduated return to full activity may occur when full motion, normal muscle strength, and the absence of swelling resume. A brace is often used in the return to activity and may be recommended for up to 1 year or longer.
Really, it got better every week. I noticed some improvement. But after about 3 months, you're feeling pretty good and you're actually going back to pretty strong exercises. I really wasn't comfortable running all-out sprints or cutting until about 6 months or so.
Both the surgeon and physical therapist monitor rehabilitation closely. They caution against any premature return to full activity, which might easily cause the knee to become inflamed or re-injured. Complete success in an ACL reconstruction cannot occur until the graft has both healed into place and been incorporated into the knee. Putting too much stress on the joint prematurely increases the risk of graft failure. Although surgery for an ACL tear is usually without any significant problems, there occasionally may be unforeseen complications associated with anesthesia, including respiratory or cardiac malfunction. The surgery itself may be complicated by infection, injury to nerves and blood vessels, fracture, weakness, stiffness, or instability of the joint. The vast majority of patients who undergo ACL reconstruction experience no complications. Those who follow the recommendations of a physical therapist usually return to full activity within the first year after surgery.
After about 9 months to a year, I was pretty much back to normal. I was playing football and racquetball and doing pretty much everything I wanted to do without any trouble.
For more information on ACL injuries and their treatment, contact your physician. Other Dynamed.com patient video programs are available by contacting the Dynamed.com website.